I guess you can start.
Uh, Good morning to one and all present here. I hope you're having a pleasant day so far. I am Sharanya Ramesh Dumde Patil, and I will be your host for the day. It is with great privilege and pleasure that we extend our warm welcome on behalf of Amity University, Mumbai, the distinguished lecture series on biology of tuberculosis. Our inaugural lecture features the esteemed presence of Professor Sarman Singh on eliminating tuberculosis from India by 2025. This series is organized by Amity Institute of Biotechnology. Tuberculosis is one of the deadliest infectious diseases with 1.5 million global deaths and 3 million fresh cases in 2021. The organism responsible, Mycobacterium tuberculosis, has plenty of time to adapt to its chosen habitat, human lungs, and has learned through natural selection to be almost perfect pathogen, using our own immune system cells as Trojan horse to aid its spread. It comes up with clever ways to avoid being killed by antibiotics. But patience has been its biggest lesson. It can enter into a latent state, and when times are tough, only to come back to life when host immune system is compromised. Today, more than 1 million people die of the disease every year, and around one-third of the world's population is believed to be infected. That is more than 2 billion people. Throw in uh, Throw in the compounding problem of drug resistance, the HIV epidemic, and poverty, it is clear that tuberculosis remains one of the most serious problems in the world of medicine. As we embark on this intellectual journey guided by our insightful and perspective esteemed speaker, let us collectively explore the strategies, advancements, and concerns that poised to shape the landscape of tuberculosis control in India. The vision of eliminating tuberculosis from our nation by 2025 is not just an aspiration, but commitment towards a healthier and thriving society. That said, I would like to introduce Dr. Penna Suprasanna sir. He was former head of Nuclear Agriculture and Biotechnology Division of the ARC Mumbai and former professor at Homi Bhabha National Institute, Mumbai, India. He has joined Amity University as a Dean of Research, Professor and Director of Amity Center for Nuclear Biology and HOI of Amity Institute of Biotechnology, AIB. Now I request Suprasanna sir to share the welcome address.
Thank you, Sharanya. Honorable Vice Chancellor sir, and all the eminent dignitaries who have joined online for the lecture series on biology of tuberculosis, and Professor Sarman Singh, the expert who is going to deliver the talk. Welcome to you all. As Sharanya has already put forward the background, she has set the stage about tuberculosis. It's the deadliest disease, as all of us know, and there is a lot more to do to eradicate and then keep the rate around 10% by 2025. And it requires a lot of major breakthroughs in terms of vaccines, in terms of diagnosis, in terms of more research in understanding the pathogenesis and treatment. So I welcome to you all once again, and thank you, Sharanya.
Thank you so much, sir. With that, I would now like to introduce Honorable Dr. Professor A.W. Santosh Kumar. Sir has been in academics for 33 years and has been Vice Chancellor for a period of 4 years in one of the most highly ranked universities. He has published 181 peer-reviewed articles, 4 books, and 12 book chapters. I would request sir to give welcome address. Thank you, sir.
Thank you, Saranya. Respected dignitaries, beloved Professor Sarman Singh ji, Suprasanna ji, our Deputy Pro Vice Chancellor, Dr. Daima, our deans, directors, HOIs, faculties, and my dear students. It's indeed a very great pleasure to join this forum, not as a Vice Chancellor, but as a microbiologist. So I date back to my earlier thing. There is one correlation between me and Sarmanji is that I am an alumni of AIMS New Delhi, and Sarmanji is the former director of the new AIMS at Bhopal. So a great person, great microbiologist who had done a versatile work on leishmaniasis, and the most important thing is that he has taken up a direct position during the verge of COVID, where he had done a great paradigm shift at at AIMS Bhopal. And I'm indeed very happy that I'm a part of this lecture. I really congratulate and thank Dr. Shashank for bringing this elite person, and all our students I see in the panel, that many of our HOAs who are not at all related to microbiology and biotechnology are a part of it, which clearly says that TB is a very important disease, yet to be eradicated, cannot be eradicated. And earlier it was called as a king's evil, but at the same time, it's still an evil existing in the world. Without further ado, I really thank again for Professor Sarmanji for taking a time out and giving this good talk to the students, because this kind of a gesture I see very little from elite and great people and the senior ones. And I really thank you, sir, for having come here virtually, and we look forward to inviting you in person soon. Thank you very much. Over to Karan.
Thank you.
Now,
Professor. Yeah. Saranya, please go ahead.
yes, I will now request Shashank sir to introduce our today's speaker. Over to you, Shashank sir.
Professor Santosh Kumar has already introduced. I think we are already time constant, so I don't think that is a need.
Sarmanji, if that is the case, I have missed one important thing, that Sarmanji is a BC Roy awardee, which should be the first one I should have told. I forgot it at the head. Yeah.
Okay, so thank you, Honorable Vice Chancellor Sahab, Dr. Santosh Kumar. He very, new thing came up that he passed his, he is alumnus of AIMS Delhi. Which year I don't know, but I served AIMS Delhi 33 years, and then I shifted to AIMS Bhopal, from where I retired. So, Dr. Kamble, your Dean, Dr. Panna, I can say Dr. Professor Sunil Kumar, Dr. Dahima, and many other deans, sub-deans, associate deans, head of the departments. Thank you all, especially Dr. Sasank, for giving this opportunity. Of course, I will not take much time in introductory remarks and other Thanksgiving, because we have already 30 minutes, late. So I will start my screen sharing, and let us have. Can you, my screen is visible?
Yes, sir.
Yeah. Okay. Great. Okay. So as Saranya very nicely said, that we know that tuberculosis is one of the greatest problem, and Honorable BC also said that it is a happy thing that cross academic disciplines they have joined, and it is true that tuberculosis, I will show you some of the figures, that it is not a one particular specialty. It is a disease of humanity. It affects all walks of life and all concerns about the society, the economy, the governance, and everything is affected by that. So therefore, I am sure that everybody is aware that World Health Organization has aimed to eliminate tuberculosis by 2030, and our Honorable Prime Minister Narendra Modi ji, he gave a task to all of us to, eliminate it by 2025. It is true that whatsoever head of the governance or head of the country says, we have to work for that in that direction. But it is also true that how feasible it is and how effectively we can implement the desires of our Prime Minister. This we will see in few of these slides. I will go a little faster because already, as I said, that the usually I prepared for 1 hour, but it looks that we have already chewed up our 30 minutes. So I will be a little faster for some of the slides. So tuberculosis was also or is still known as various other names, like in Hindi, it is known as Yakshma, Tapedik, Chero, TB, and all these things. So earlier it was a disease in European countries, and still if you go to Europe and Switzerland particularly, you will find many of the sanatoria at hilltops. So those were the time when there was no treatment, and then at that time, the only sanatoria or the fresh air with morning sun. This was the only treatment, and unfortunately, now it has become a disease of the developing countries. Europe, most of the European countries and America, they have now controlled or eliminated the tuberculosis. So now the obviously we know that Mycobacterium tuberculosis is the causative agent, and the commonest source of infection is human to human. Sometimes some cases of bovine infection they are also reported, which usually come through the infected blood if the milk is not boiled or parboiled. Then obviously the it is a highly communicable disease. So one patient to another person is you know infected, and the mode of transmission is through the respiratory route. This is also a disease where there is no age is immune to that, and no gender whatsoever you say. Of course, nutrition plays very significant role. So malnourished people, they are more likely to have infection, and there is no I'm sorry. So then malnourished people, they will have more likelihood of having developing tuberculosis, active tuberculosis, what I mean to say. And immunity, there is so far there is no lifelong or innate immunity for that, even though vaccine is given BCG, but that is only effective in protecting from the uh, meningeal disease or some form of the disease up to 15 years or so. Recent study I will show you published, we are one of them, the biggest study published in Lancet last year. So we have clearly, meta-analysis has clearly shown that the biggest effect or the most protective effect remains only 5 years, and then almost after 15 years this effect is totally gone. The social factors are very very crucial. So obviously the poor quality of life is very important. Overcrowding is helps in the spreading of the infection. Of course, this is because of the economic regions or and both combined. Education, and then if they don't have obviously the affordability of having the open houses, and then large family size, these are some of the factors which are obviously they are directly connected with the high rate of tuberculosis. This is unfortunately the dark areas. You can see these are the countries where tuberculosis is highly endemic. And here you can see this is India, and in India we are having very high rate of tuberculosis. Of course, there are some African countries and some of the countries in the Indonesia, some and then except these countries, most of these countries they have done very well. In 2021, again, the TB situation is, again, if you see the share of the tuberculosis cases, this is India. China used to be earlier, but now China has controlled it to a great, deal. And now India remains the biggest country, which is having also the highest number of cases. earlier China, because of the population of these two countries, but China has really done fantastically well. India, unfortunately, is not doing that well. The causative agent, I am sure that most of the students, they must be knowing, those who are working on tuberculosis. This was causative agent was identified and presented in Berlin conference by Robert Koch on 24th March 1882, and after that the 24th March every year we celebrate as World TB Day. It is a bacilli, very tiny bacilli, about 2.2 to 2.5 micron in size. Mycolic acid is the hallmark of the bacteria which is present in the cell wall, and because it resists the decolorization after once you stain the bacteria, and this resistance to decolorization makes this name as acid fast bacilli or acid fast bacillus. This is usually non-motile, aerobic, and obviously it is the multiplication rate is very, very slow, about 18 to 20 days, duplication time or doubling time. TB is fortunately curable, provided it is diagnosed early and correct and timely initiation of treatment is made. The speciation, and if it is having drug resistance, then if it is tested timely, that is also very, very important. And regular supply of the medicine means if the patient is not taking medicine regularly, even though it has been prescribed, then it will be a real problem. And then compliance, as I said, it is very, very crucial, because many of the cases, non-compliant patients, they develop, not only disease continues, but also it develops resistance. There are many regions which are well known to have the unfavorable outcome, means treatment failure, that if the above mentioned conditions they are not met, and if the patient is old, and then if there are comorbidities, means the patient is having some other diseases also, like pulmonary diseases, cancer, diabetes, smoking, alcohol, that these conditions, they help in not curing the disease. So these are the some of the regions that some of the patients, despite taking medicine regularly, they will not respond to the expected lines. Because of these reasons, here you can see there are a very high number of the, if you can see my cursor, this is the number, very huge number of the patients they lost to follow up, or they are not evaluated, or they do not comply with the drug. So this is very, very significant number. So here you can see about this green bars, you can see about 45 to 50% patients only, they are cured and treated successfully with the first line drugs. So that leads to the multi-drug resistance, what we call. So this is not cured or not taken care by the standard drugs what we give, that is rifampicin, INH, and ethambutol. So they develop resistance to these drugs, and obviously the other drugs or second line drugs, they have to be given. So again, unfortunately, India, here you can see India is still the biggest burden. And some of the factors for MDR, which many of these regions I have already mentioned to you, that the lack of laboratory capacity, there are no conformity diagnostic things, even though government of India is doing a hard fight, giving hard fight to TB cases, but there are some limitations. So here you can see that what I was saying, that government of India is trying its best, that massive expansion of the services. You can see about 10 years or so back, it was really not that the services were not spent well. But here you can see that we have up to 6 national reference laboratory, 34 intermediate reference laboratories, huge number of laboratories, about 58. In addition to these national reference and intermediate reference laboratories, there are another set of laboratories which are known as culture and DST laboratories, which are there in India. And then we have the nucleic acid amplification testing laboratories, which are huge number, more than 3,700 till last year. And then we have, sub-district laboratories, DMCs, where microscopy and treatment can be given. So here you can imagine that government has expanded the TB care services in last 10 15 years uh, to a great extent, but still, as I said, that default rate and uh, treatment failure rates are still very high, which are probably worst in uh, top 10 countries. Some African countries we have worse than us, but most of the countries we are the level what we are having because we are counted as the developed or near developed country. In that, if we see, unfortunately, this is one of the blot on our image of the developed world. Now, the obviously key points are they were discussed, that how to deal with this. So, how much cure we should have, how much treatment failure we should have, and how much
Dr. Shashank, there is some problem, audio problem.
Yeah, sir, I'm here only. I think there's some problem with the internet. I'll just get back to him.
Oh,
tuberculosis is not infectious to others, but obviously from others we can have any type of tuberculosis. So once it goes into the lungs as a primary filter, and then from the lungs it goes to our blood, and from blood it
Excuse
can,
me, sir.
yeah,
Uh, your screen is not being shared. Sorry to disturb.
is it?
Yes, sir. It stopped sharing.
So which slide you are seeing?
Right now, we're not seeing any slides, sir.
Mhm.
There was a network issue, so I think
The
your
but I
audio
am
and
connected. How come?
stopped.
If I am connected, then my slides should also be seen.
So you may reshare it.
Okay. What was the last slide? This slide, did you see? Can you see this
It
slide?
was
No,
the
no.
slide number 13.
13, 13, 1 3. 1 3 was the last.
Can you see this slide?
Yes, sir. Yes, sir.
Okay.
We can see.
So, okay, great, great. All right. So, the transmission, obviously, the susceptibility I have discussed, I will not give much time, but definitely the infectiousness is very important, but environment, I have already discussed indirectly how the family size and the crowded places, they all help, and how the proximity, frequency, and duration of the exposure, they are directly responsible and related to the possibility of uh, having infected. So these are the some of the factors. Obviously, I could have given much more time to deliberate on these, but definitely if the questions come, then I will come again. So here, the obviously the most important site involved is about pulmonary uh, uh, site, that is lungs, first filter, because we get the infection through the respiratory route, and then of course extrapulmonary tuberculosis about 15 to 20% cases we do have other forms of the tuberculosis, means outside the lungs. So could be the lymph nodes or genitourinary tract or intestine, sometimes even skin, brain, meninges, the bones, joints. So all these, the organs can be involved. In AIDS patients, usually this proportion of the pulmonary and vis-a-vis extrapulmonary, if you see, this is a little bit changed, because usually in HIV negative patient, the ratio is 85 is to 15. But in HIV positive patient, it goes up to as high as 20-25. So say, for example, 75 to 25 or 80 to 20. So that is there. But fortunately, not many cases of HIV, TB are seen these days. But earlier, when the HIV was on its peak, this was a major problem. So these are some of the how it happens and various organs, how they are involved. I will not go into much detail, but definitely the the T cell are most crucial. So the if at all we are protected from the active disease, or when the mycobacterial infection takes place, but we don't get the disease, that means it goes to latency. So this latency or developing an active disease is mediated by T cell immunity. So T cells or the cell mediated immunity has most important role. Antibodies, as obviously they have hardly any role in that. So cell mediated immunity is most crucial. Then how it happens, so again the pathogenesis and how the immune system works and how it forms the necrotizing lesions and granuloma. That, this itself is a slide which one can devote 5 minutes or so, but in the interest of the time I will not go into detail. But the bottom line is that cell mediated immunity and T cells, they are most crucial to develop whether the patient will go to the latency or means developing a cagitation and necrotic lesions or micro necrotic lesions, what we say micro granuloma. But sometimes if the immunity is not sufficient enough, then we do have active disease. There are obviously various diagnostic methods to diagnose the disease. It could be the most uh, important one still remains the sputum examination or the pleural fluid. Then you can have various type antigens can be detected, or the ELISAs can be done, or various other tests can be done. But obviously the antigen detection is having a limitation, that it is the antigen quantity in the blood is very less, therefore the sensitivity is not that great. There are obviously in last few years lot of upgradation in the laboratories has been done. If you remember, I did so you the slide that the massive expansion of the laboratories, the diagnostic services as well as treatment services has been done. And in that direction, liquid cultures, molecular techniques, and drug susceptibility tests, they have all been done, but probably it seems that they are not yet sufficient. So more has to be done. This is the smear microscope, which everybody knows probably. On the left side, you can see the conventional acid fast stain, and on right side, it is a the fluorescence stain. Then liquid cultures machines, then obviously the interpretation of how the acid fast staining, the smear microscopy is done, and the grading of the smear is done. Sorry. Then molecular test. So obviously the in the molecular test, the PCR remains the most crucial. Then there are fast-based assays. They came, but these days they are not in much demand. Then earlier the gene probe, rapid diagnostic test, they were also there. Then there are various molecular beacon-based tests. There are commercial tests, including the Ross Amplicor or line probe assay, which is still the endorsed test by WHO and Government of India. So that is for drug susceptibility. Of course, it diagnoses, but mainly it is used for the drug susceptibility. And then, of course, the game changer is Cepheid DNA expert, which probably most of us know. And then sequencing can also be done. This is a multiplex PCR. In one single PCR tube, you can detect the Mycobacterium genus as well as Mycobacterium tuberculosis species and other species also, like Mycobacterium avium, Mycobacterium kansasi, and other NTM. So in one single tube, you can make 6 results, whether it is a TB Mycobacterium species positive or not. If it is positive, then whether it is a MTB or what. So like that. I will not go. This is our some work, which I will not go much detail about this one. And then you can have the ITS based PCRs also, and to speciate. Then you can have the LAMP assay, that is obviously the uh, only single type of temperature. You don't require the multiple amplification at multiple temperature and annealing. So this is considered to be isothermic, so single temperature. And here it is also another advantage that you don't require detection modalities. If you have, of course you can have, but otherwise usually by naked eyes you can see tube number 1 and 2, they are negative control. So this is naked eye without UV light. You can see that differentiation positive and negative. So rest of these right side tubes, they are positive, and left two tubes, they are negative. So you can see, but if you have the torch of the UV light, then obviously you can make out that how fluorescent, strongly fluorescent tubes they are. So depending on the which chromosome you are using. Then you can have real-time PCR, and obviously various methods are there. And then sequencing also in last few years, about 10 years or so, in Western world, direct sequencing is also being done on the clinical samples. But of course, in India, Government of India has installed the sequencing machine in 6 centers, TB centers. Unfortunately, very few are still capable of doing this as a service. So this is some of the regions that probably the trained manpower is not available. And if trained manpower is available, we don't have sufficient funds for that. So obviously, if we want to eliminate TB by 2025, the huge push of the grants or the money inflow is required. So that is very, very important. This is a direct sequencing is very good, and you can have the result within same day. Unfortunately, as I said, there are some limitations. So because of that reason, it is not being done. But of course, commercially available, some of the laboratories, they are doing it. Then of course, game changer, as I always say, is the gene expert, which has really made this whatsoever success we are having today in the TB elimination program. Mainly it goes to the gene expert, which came and endorsed by WHO and the India government in 2011. So in last 10, 11 years, it has done really significantly well. The most important USP of gene expert is you don't have to manipulate the sample. That is the most crucial thing. So the sensitivity, specificity is also very high, and you can directly use the sample, and 90 minutes you can have the results. But there were in the beginning there were some issues in the particularly the probe E, and then there were some papers. Our paper was also uh, contributed significantly, and then of course after that, the manufacturers, they changed the probe E, and now after that they have brought new, uh, gene experts like Ultra and XTR. Then, as I said, the solid phase hybridization assays, the most important are line probe assays. They are the obviously the reverse hybridization technology they are based on. So they are again the second test, probably the one is Gene Expert, which is endorsed by WHO for the diagnosis, and this is the test. Line probe assay is the test which is endorsed by WHO for the drug susceptibility, rapid drug susceptibility. So this is very good, having very high sensitivity as well as specificity for most of the drugs. And this is the principle. I will not go into detail. And then you can have the line probe assay for the first line drug resistance or the second line drug resistance, and how the all the bands and interpretation you can do various enzyme or the genes are involved here, gyrase, RRIS, EMB, and like that. Then there are other tests which are like breath analyzer. Also, they are very, earlier we have the very interesting history about the breath analyzers. Probably some of you, those who are of my age, probably you might be remembering that in our childhood, some of the Hakims and Vaidis, they used to smell, and they could tell that the person is having typhoid fever or not. So because we know that salmonella is produced as the fruity smell because of the ketones. So that was the basic principle. On the same line, there are some animals also, they can breathe the various diseases, including tuberculosis, with very high accuracy. So in that line, these days various volatile compounds, they are being utilized, and they are being used to develop the products. So one, probably some of you might have heard that e-nose. So means on the nose you can put the some device, and you can analyze the volatile compounds. So, in that direction, one company from Israel, so they tested, they developed the device, and they selected our laboratory in India and one South African laboratory. So this evaluation was done. This is how it is better than eNose, because sometimes the young children and those who are having the COPD or something like that, they cannot have the good exhalation of the breath, and then obviously the analysis is not good. So in this, what they did, that on the same principle, but they developed the um, what we have, probably I am sure that everybody must have seen the band-aid. So like band-aid, this band type device is there. So we used to put it on the arm, one on the arm and one on the chest, just like lead of the ECG. And after that, the VOCs are analyzed. And then this was definitely found to be very good, and probably in coming year, this was published last year, and then in coming years, probably this will be commercialized. There are many other molecular tests which are obviously in pipeline, and they have been developed. Most of these are successful, but they were some are in the clinical trials. But in that direction, one important thing is that probably uh, India and we all are proud of that. One important thing is that we have
We're sorry for the interruption. Dr. Sarman Singh will be joining in a while.
response to TB. And in that direction, not only diagnostics but treatment are also being planned. But there are still a lot of scope for developing various biomarkers to have the immunological, profile or transcriptomic profile, including the proteomics or metabolomics, and obviously combination of these markers. So as I already mentioned, these are the giant African pouch rats. They are also being used, as I said, in the direction of the detection of the VOCs. And then, as I said, this is the study which was done in our center at AIMS Delhi, of course. And then this, interestingly, what we found that, if you do the comparison between the Africa and India, our environment was real problem. So the BOCs, what I see, that even if they are commercially available, probably in other countries, this can be very useful. But probably in India, this may be a limiting factor because BOCs probably they will not work as good as in other conditions, other countries. There are obviously I will not give much emphasis on that, but there were a lot of hue and cry on the serodiagnosis tests, and obviously uh, in about 2012 and 2013 the WHO recommended that they should not be used at that time. The test at that time, they were commercially available. There were about uh, 40 types of tests, all based on the antibody detection. So they were detecting the LTBI and other cross-reacting with various other uh, mycobacteria, and therefore this decision was, after several meta-analysis, it was decided that the tests which were in market at that time, they should not be used because of the very low sensitivity and specificity as well. So in 2013, these tests, they were all banned in India and abroad also. We also did, and we also found very high cross reactivity and very low sensitivity as well. So after that, obviously, this was banned in India also. But WHO and Government of India always said that there is always a scope to develop newer or innovative technologies. And in that direction, obviously, everybody is working. Many of the laboratories, they are working in India and abroad also. Whether it is antigen based or antibody based, it doesn't matter, but it should be highly specific and accurate test. So in that direction, obviously, we developed some of the antigen based tests, and the idea of these tests came when we found that two patient, in fact, two patients, uh, while they were on treatment. So in the beginning of the treatment, they were susceptible to all drugs. During the, of course, the patient was not taking regular drugs. So in between, he became resistant to two drugs, and then slowly he became, within 9 months or so, he became too resistant to most of the drugs. So this is the profile, the isolate A, isolate B, and isolate C and D. You can see four, isolates we could make from this patient when he was transforming. The mycobacteria was transforming from the susceptible to resistance. So a huge number of overexpressing genes and proteins we identified, and finally we narrowed down to using various tools, of course. So we narrowed down to 5 antigens, and these 5 antigens they were tested in various platforms, and we could see that these antigens, they are highly specific for tuberculosis, and not only tuberculosis diagnosis but also to differentiate between the drug susceptible and drug resistant mycobacteria. Here you can see, I'm not going into detail. This paper is already available, so anybody can read details of this paper. And then this was on the based on blot and ELISA, and then finally, ultimately, our aim was to develop a rapid diagnosis so that how it can help the elimination program. So these ICTs we have prepared. So as I said that 4 best antigens be plotted. This is control, of course. Here you can see on left, most bright, and then we spotted these antigens. So here you can see
Excuse
in
me, sir.
positive and, negatives. So these plots you
Sorry
can
to
see
disturb you.
just only few slides. So the
Yes, sir.
algorithm was
The slides are not.
sorry.
The slides are not being shared, sir.
Again,
Yes, sir.
hmm, technology has to be good. So this slide,
Yes,
I
sir.
don't know.
Thank you, sir.
This slide you saw that this one. So this is the
Yes.
basically what I was saying, that the idea was that how the test could reach to every household and clinics, because no test which is whether molecular or serological, which is big laboratory based, or requires big setup, will help much in the TB elimination. So the idea is that any test which is developed which can reach to the doorstep and can be used as a triage, if not for diagnosis, because sometimes triage tests, they have very significant role in the screening of the population. So this is the here you can see in this patient, say for example, this is control, and then all these antigens highlighted. So this was, we found very good performance of this test, and this is being thought. This was published, of course. So this we are thinking to commercialize it, just like we did for the leishmania. And some companies, they are in the discussion, but of course, as you know, that the people are not coming forward so aggressively. And this is again, this was earlier we developed how it is so specific that it will not have cross react with the healthy control, and also not with the disease control. So we are confident that if it is rolled out in the program, then definitely this can help to a great deal. And I think with these words, in last, I would like to say that TB can be eliminated. Obviously, by 2025, I'm not sure, but definitely can be eliminated. If not 2025, maybe 30 or 35, provided we have early diagnostic tools, and most preferably screening test or rapid diagnostic test, which can is a uh, point of care. And then also speedy drug susceptibility testing has to be there in place. And the last but not the least, the social awareness is very important. As I again and again said, that tuberculosis is not a disease of to be dealt by the microbiologist or medical doctors, but every one of us. So I think with that, I would like to thank you all for patient hearing.
Thank you so much, sir. Now I would request Dr. Sashank Kamble, sir, Assistant Professor at AIB, to give vote of thanks.
So I
Sorry, I
hope there are
was,
no questions
uh,
from the students. So it is our pleasure to have Dr. Professor Sarman Singh with, and as per the purpose of organizing this lecture series was to make the students and the faculties aware about the tuberculosis scenario in India, and even to make them incline more towards the TB research. And I think that purpose has been solved by Professor Sarman Singh. He has transitioned beautifully from very basic things about tuberculosis biology to the complex situations and complex studies. So being a TB researcher, it was indeed a privilege to attend his lecture. So I thank Professor Sarman Singh. Along with that, I thank Dr. A.W. Santosh Kumar, Honorable Vice Chancellor, for encouraging us to uptake this lecture series. Dr. Penna Sulpasanna, HOI AIB, he has always supported us and guided us to pursue high dreams. Along with that, the organizers of this event, Dr. Abhishek and Dr. Ramesh, along with myself, and finally, not the last but the least, the students who basically, I think they have turned up into huge numbers. and I think they will be benefited by a large margin to this for this through this series. And along with that, all the dignitaries who have joined, uh, Dr. Sunil Dhaneshwar, Professor Sunil Dhaneshwar, and Dr. Vijay Singh Daima, and apart from that, other dignitaries who have joined. I sincerely thank all of them for your gracious presence, and including all the HOIs. So thank you so much. Is there any question from the students? If you have a question, you can ask the question by unmuting your microphone. Even I think faculties also, if they have any question, they can ask.
They can raise hands, otherwise, obviously.
Yeah. So I don't think there is a question.
Yeah.
So
They are
thank you,
all
sir. Thank you so much, sir. Thank you so much.
Dr.
And
Shashank, can I
sorry for
ask a
keeping you
question,
waiting.
please?
Yeah,
Dr.
sure.
Shashank?
Please. Yeah.
Yes.
Sir,
Yes.
good morning. What a fantastic talk. Professor Sarman Singh, sir. I have been working on tuberculosis, where we developed certain bioreversible derivatives to overcome the hepatotoxicity of isoniazide. So, sir, my question to you is that apart from the resistance to the anti-tubercular drugs, the another issue that one faces is the non-adherence with the therapy because of the adverse effects of the drugs, even if it is first line or second line drugs. So I wanted to ask you, we hear about the cocktail therapy and all. So from the clinical point of view, how do you deal with the hepatotoxicity of the anti-tubercular drugs?
Very important question, because this is the one region where, because rifampicin and INH both are hepatotoxic, and obviously sometimes the reaction is so vigorous that the patient is not only is asked to cease the medicine but also to get admitted, because sometimes the itching and jaundice is severe, and vomiting and gastric
Yes.
irritation, they are huge, and very sometimes they are not tolerable. So definitely, if you have anything, I would suggest that you should go for the clinical trial, and if they can have, but again, the clinical trial has to be planned in such a way that not all patients, about 93 to 94% patients, they will not have any side effect. So this has to be taken into consideration, because only about 6 to 7% patients, they will have side effects, or the intolerable side effects to the INH and rifampicin. So if you can have this kind of patient, how the study has to be designed, that how to know. We don't have any parameter. Again, as I was saying, that there are lot more research is required, that we don't know before giving treatment, that who are the patients who will develop side effects and who are the patients who will not develop. So even though same drug, same manufacturer, and the same nutritional or BMI, what we say, everything is same, but some patients, they will have genetic structure is different. So
Yes.
some patients, they
Yes.
will develop, some will not. So whenever you are designing your clinical trial, which I strongly suggest that you should go for that if you are having any such molecule, irrespective whether it is IUs based or uh, you know uh, uh, you know any chemical, but the RCT has to be very carefully designed. But if that comes out to be good, definitely it will have lot of impact.
Yeah, thank you, sir. I just wanted to ask, as from the clinician's point of view, how the doctors are dealing with the hepatotoxicity. I mean, which combinations they are prescribing so that the patient adherence to the therapy is more.
Yeah, so that's what I was saying, that usually patient has to be, if they are tolerable, then you usually we give some supplementary drugs, they are there, B complex, folic acid, and all these things. But if this is not tolerable, then the patient is asked to stop the treatment for 15
Okay.
days, and then slowly the again he is started
Okay.
again, second time also he develops. Obviously the other drug has to be given.
Mm-hmm.
Cannot continue with
Because we have heard that anti-tubercular therapy once started, you cannot miss a single dose.
Yeah, should not.
Yeah.
So one last question from my
Thank you,
side.
sir.
Yeah, so it is already established that having tuberculosis can, we can have the common or the overlapping infections of tuberculosis and HIV. And in the COVID outbreak, it was established that, or it was proposed that, having BCG vaccination may prevent against the COVID pathophysiology. So, do you think is there any, link between having tuberculosis and getting COVID-19 or vice versa? This is the first question. And the second question is that is it possible to develop a non-invasive diagnostic test for latent tuberculosis?
The first question, yes, BCG, because as I said, the immunopathogenesis or immunology of the TB is that BCG also promotes T cell immune system. So that because it is not only for COVID, it is well known for many years that BCG and sometimes even the PPD itself, many patients in a clinical sense, when doctors, if you ask, they will vouch for that, that many patients, they have taken BCG for any other purpose, means for vaccination, but they got cured of many other diseases, which are usually the chronic diseases like asthma, some rhinitis cases. So they do, get cured because of because immune system our is triggered. So that is the one. So it is true that it helped COVID prophylaxis as a prophylaxis. The second question so far, because the non-invasive, if you say the not even a needle, then there is no test for obviously the for diagnosing latent tuberculosis. But if needle is, you think needle is not an invasive thing, then obviously there are tests. Blood has to be taken out.
Okay, thank you so much, sir.
Yeah.
So
Thank you.
sorry to keep you waiting in the
No
initial
problem. No problem.
beginning
Yeah.
of the talk. So
Thank
I
you.
think no questions are there from anyone, so we can end the meeting. So we really thank Dr. Salman Singh for his wonderful and highly informative session today to kickstart this inaugural series of the tuberculosis biology. Thank you
Thank
so
you.
much.
Thank you. Thank you.
तुमने बात
Answer. Hello,
Hello?
sir. Can I close the session now?
Yeah. Sure.
Okay,
Thank
sir.
you. Thank you. Sure.